just quickly review what we said today. So we have the basic battery of tests, which the basic battery of tests are CBC, ESR, which we usually perform with urine analysis, chest X-ray, or even better, CT scan of the chest, tuberculous skin test, FTA, ABS, and VDRL to rule out syphilis, brucella titer, brucella serology. And we said we usually also, before giving systemic medications, we have to also investigate for serum electrolytes, liver function, kidney function in the form of blood urea nitrogen and serum creatinine, and a pregnancy test in any female of childbearing age. So these are the basic battery of tests that we perform in uveitis. We gave a scenario of a posterior uveitis, a young lady with blurring of vision and floaters of weeks in one eye. She had a quiet anterior chamber, and she had this chalky white appearance in the retina. And we said, well, this is an acquired toxoplasmosis. We gave a differential, and these three infectious etiologies, two infectious etiologies, toxo and tuberculosis, are common inside together with Behçet disease. But we said Behçet disease is usually more small and focal, and more of a retinitis than a choroidititis. But we still need to investigate for all three. Toxo titer was positive. All other investigations were negative, including the BBD. We give another example of a granulomatous disease with the headlights in the fog phenomena. Okay? And we mentioned that we have two differentials for the headlights in the fog: acute retinal necrosis and acute toxoplasmosis and acute retinal necrosis. By history, usually there's history of ingestion of raw meat or semi-cooked meat, and fiddling or with cats, with infected cats. We gave a third example, also headlights in the fog with a peripheral necrosis of the retina, and we mentioned this to be acute retinal necrosis. And we mentioned the importance of therapy in hastening the recovery and reducing the possibility of involvement of the other eye. And we should not start steroids before giving IV acyclovir. Otherwise, we can worsen the systemic condition. So the acyclovir precedes the systemic steroids. We give a third example of a patient with reduction of hearing, granulomatous disease, and exudative detachment of the retina, with shifting of fluids, with tinnitus, VKH. All investigations are negative. We said this is a clinical diagnosis. We can further confirm our diagnosis by performing a fluorescent angiography, which will show this Milky Way appearance, pinpoint leakage, which accumulates into an exudative detachment due to accumulation of fluid. There's also thickening of the choroid. We gave another example of a patient with oral ulcer, hypopian, bilateral, non-granulomatous, with retinitis, areas of retinitis. Okay? We measure this to be Behçet disease. What's very important about the characteristics of a Behçet disease? The oral ulcers can occur in the lips, in the buccal mucosa, in the gum, in the tongue, everywhere in the mouth, even in the palate. It's usually painful, recurrent. You need at least 3 ulcers in 1 year. At least 3 ulcers in 1 year. This is how frequent it should be. Will they heal with scarring or without scarring? They will heal without scarring. The same applies for the genital ulcer. It's painful. It's recurrent. It heals without scarring. Okay? Is it clear? Oral ulcers. Genital ulcers. We talked about the uveitis. And what's the fourth? And fifth, skin lesions, they have pustules. These pustules are they're sterile pustules, collections of neutrophils, just like the retinitis, which is a collection of neutrophils. And positive pathology test. Positive pathology test. If they are pricked with a needle, they develop pustule. They will develop a pustule due to hyperactive neutrophils. So what are the major criteria of Uveitis disease? Oral ulcer, genital ulcer, skin lesions, positive pathology test. The oral ulcer is painful, recurrent, they heal without scarring, and can occur anywhere in the mouth. The same applies for the skin lesions. The minor criteria, GI involvement, CNS involvement, vascular involvement, okay, which are less important. You need at least more than two or more major criteria to secure a diagnosis. Okay. HLA-B51 can further confirm the diagnosis. We talked about in fluorescein angiography they have pan leakage due to breakdown of the inner blood-retinal barrier. We said in uveitis we need to exclude infection and malignancy before we start therapy. We talked about different types of therapy and the importance of having a strong and swift response to prevent permanent damage to the inner or outer blood-retinal barrier or blood-aqueous barrier in order to prevent fast bulbi. The eye should not be operated while inflamed. The eye should be without inflammation for at least 3 months. We talked about the inner blood-retinal barrier, which are the blood vessels of the retina, the outer blood-retinal barrier, which are the RPE layer, and we talked about some of the aftermaths of uveitis: peripheral anterior synechiae, posterior synechiae, occlusio papillae, total posterior synechiae, glaucoma, and cataract. We mentioned that cystoid macular edema is a manifestation of breakdown of the inner blood-retinal barrier. Exudative detachment is a sign of outer blood-retinal barrier, and permanent damage of the outer blood-retinal barrier may manifest itself as coronary membrane. We talked about the complications of steroids: moon face, buffalo hump, osteoporosis, and it is important that patients should follow a healthy lifestyle, eating healthy foods, avoiding junk food, activity. They need to be supplemented by vitamin D and calcium. And we talked about who are those at risk of developing osteoporosis and how sodium androgen should be given once weekly to reduce this complication. There should be a restriction of salt intake. Liver function, kidney function should be performed every 3 to 4 months. And we talked some of the side effects of anti-tuberculosis, such as ethambutol and azithromycin, which can cause central or paracentral scotoma. In ethambutol, it's reversible. In INH, it is irreversible. When we give INH, we usually give with it vitamin B6 to reduce the peripheral neuropathy. We should screen the patients for visual acuity, color vision, and visual fields to detect these complications. You see pyridoxine, vitamin B6, together with INH to reduce the incidence of peripheral neuritis. Okay, so this concludes part 2 of today's lecture, and I will now leave the floor to Dr.